James Davis.
Thank you, Chair. John Butler, as a GP, obviously, you can imagine I'm a big fan of our primary care system, but do you think to an extent one of our problems is that GPs in this country are too effective as gatekeepers and are not letting people through, and that actually the systems in place in many other countries do make that direct access to secondary care clinicians easier?
Yeah, and thank you very much for the question. So we did a piece of work with the ICBP offering clinicians from around the world the same clinical vignette, so an example of a patient with, say, ovarian cancer. And we found that in lower performing countries such as England and Wales, only about 35% of GPs referred with an identical clinical history to over 60 or 70% in better performing nations. So I think certainly the threshold for referral does appear to be, based on our international studies, higher in this country. And I guess there are different ways of gatekeeping. Some is where the GP will want to conduct the diagnostic investigations, of which there may be a delay. Others may be in the sort of the, I guess, just monitoring patients and the and having perhaps too low a threshold for further investigation.
And have you looked at direct access, so even skipping the GP in some instances?
Yeah, so we know as part of this, we looked at direct access to imaging such as CT and ultrasound, and we found that was much greater in other countries. But hopefully the diagnostic hubs that are being rolled out will increase that access. But certainly there is a big variation in access to diagnostics.
Mm-hmm. So Professor Richards, sorry, Professor Emery.
I'm sorry, I hope you don't mind me interrupting. I just wanted to add to that point about the threshold issue. And I think GPs in Australia, where you have greater access to tests, then inevitably your thresholds are lowered. And I think the ICBP study that John Butler mentioned really highlighted that point. So there is a sort of a supply and demand effect that goes on there.
Mm-hmm. Professor Richards, many clinicians don't like ticking boxes. However, there is a case to which actually a very simple referral system makes life much easier. So if there are too many hoops to jump through, for instance, that is perhaps an impediment to referral. Do you think that there's too much variation across the country currently in terms of a referral criteria, referral pro formas? Should there be a level of excellence that is developed centrally to look at what makes it easy to refer and who should be referred? I know there are obviously nice guidelines as to who should be referred, but from the point of view of the hard-worked GP.
Well, certainly I would want to make it as easy for a GP as possible. And I think we do throw up barriers at each stage, but because of the lack of capacity in our system. And so I think the first thing to do is to tackle that capacity barrier. And that is, as other people have said, it is both an equipment and a workforce one. If we put in more CT scanners, we will need more radiographers. We will need more radiologists to report the scans. There's no doubt about that at all. So I think we need to build the capacity. And if we build the capacity, I think we will find ourselves making it easier for GPs to access that capacity.
Thank you. I mean, are you aware of situations where actually the capacity is there, but the referrals aren't coming through? I know in some specialties, for instance, cardiology, I remember rapid chest pain clinic was set up in an area where I was working, and they were actively encouraging GPs to refer even cases that perhaps we wouldn't normally have done so. They had a risk stratification system on the referral pro forma that suggested that almost anyone with a twinge in their chest needed to be referred, and they seem to be dealing with those patients very effectively. So it can be done, and is it being done in some parts of the country?
I think there is a lack of capacity in the diagnostic services throughout the country. I don't know of any part of the country where I would say they've got sufficient diagnostic capacity, either in workforce or equipment. But But I think if you look at the cancer referrals, which have gone up year on year, the 2-week wait referrals. I remember when the 2-week wait referral was introduced, the beginning of this century, actually the number of people being referred was way below what we had predicted at that point. It's now just about where we expected it to be, the 2.5 million figure that's been referred to earlier. That's more where we expected it to be nearly 20 years ago. So I think that has moved on, and that is, I think GPs are responding to the fact they know that we need to diagnose patients earlier, so they're making much better use of that.
Thank you. And finally, from me, we touched on virtual consultations in the previous panel, but do you feel that they've had a negative effect at primary care level or at diagnostic level, or is there something to learn and embrace from it?
My own view on that, and I've talked to a lot of GPs about this and others, is that there are quite a lot of consultations that are better done by virtual consultation. I know from my own experience that I don't necessarily always need to see a GP. I want to talk to a GP, and that may be about a repeat prescription, whatever it might be. Let's get those done virtually, or telephone conversation being perfectly sufficient. Others, people do need to be seen, and we must make sure that is the case. Then the GP may need advice. Well, that advice could be given online in many cases to the GP, and the patient sent straight to diagnostics if that is the appropriate next step. So I think we can change the old model, which was patient goes to the GP then refers to a hospital, sees a consultant a few weeks later, then gets a test done, but the test isn't definitive, so they go back to see the consultant, then get a second test done. That builds in weeks of delay, and we do have evidence now that those weeks of delay can actually affect survival and therefore the outcomes. So I think we need pretty radical change in the pathways, and I think we've seen a lot of that happen through the pandemic, and we've got to learn from that and then make sure the best of that is spread across the country.
Thank you.